So today is night. Oh, it's very cold.
Yeah, it is -5 to 0. It's usually very serene after hours, walking in the corridors.
It's actually pretty quiet at night.
Request any recess 5 minutes.
So we're on night shift.
So this is like the staff area.
That's their paediatric flight.
So it's just a testing bleep, that's fine. So just need to call switchboard, which is the operator, and tell them that the bleep is working. Every night and every day there's a test bleep. And if there's an emergency, then it will appear here as well, or any referral. So anybody who contact like the pediatrics team will come here as well. So this is where we put our stuff. Like there's a small changing area here, and it's like a locker and stuff. I just need to use the washroom because like need to make sure that that is usually empty, because if it's full and there's a cardiac arrest, then it's very inconvenient.
Sounds like you're speaking from experience.
Yes. And this is usually where we head over here.
Ooh, quite nice. That's a very creepy doll.
Yeah, and sometimes we have trainings here as well.
Ah, cool.
So I'm just having my break now. This is the kitchen. This is my food. So just a quick recap while waiting for the food to be heated. Today was like a crazy start because even before we finished handover, there was a pediatric cardiac arrest, like a pre-alert, which means they bleep us. They let us know like how soon the patient is arriving. So this was about 5 minutes. So it usually goes like pediatric cardiac arrest, and then the location like resus, which is resuscitation area in ED, and how many minutes, the time for arrival. So this was like 5 minutes or 10 minutes, then 5 minutes they would put out another call. So the registrars and I just rushed down. Yeah, then we had to resus this patient, and the patient was actually quite unwell. And then later on, the consultant actually had to come in to help out. And then while this child was being stabilized, there was about like 15 patients to be seen on PAU, and it was just quite busy. It's a little bit better now, but the child is still quite borderline unstable. Yeah, it's a bit better now, so I'm just going to have a bit of something to eat and then just crack on with the jobs and seeing more patients. I just finished my break. A few more hours to go. Actually quite tired now, but it's the last night. So this is just the waiting area where usually like patients who come into the pediatric assessment unit, they'll wait here. It's a lot of toys, like a teapot. But anyway, so basically what happens in the night shift is, first of all, we have handover, which happens in the doctor's office, and that usually we go through all the patients who are on the ward, as well as the patients who are coming into the pediatric assessment unit, or PAU for short, and patients who are already here. So that's what we did, and then usually we sort of like triage and prioritize the ones who are the sickest, either on the ward or on the PAU, and then we will see them accordingly, and then see the rest on PAU. Okay, so just a brief introduction on what a resuscitation team is, or resus team is, to elaborate if you don't know. So basically a resus team is like everybody who's usually on call for a cardiac arrest or for a resuscitation case. And for pediatrics specifically, it's usually made up of quite a lot of people actually. So usually the case would be in the resus area of the emergency department or the pediatric ED. So this is made out of, firstly, the pediatric registrar or consultant, the pediatric SHO. There would be usually then an anesthetist team, the emergency consultant, depending on the case, and then a lot of the nurses, the healthcare assistants to help out as well. So in the case earlier, we actually had about like 15 to 16 people around the bed of the patient. So imagine a tiny patient, like for a pediatric patient, they're quite small, and 15 or 16 people around, and you have the parents. There is usually people explaining to the parents. Usually it's someone quite senior who knows what's going on, because you need to explain without sort of like managing their emotions and how they're feeling, and just give them information on what's going on, but at the same time you don't want to overwhelm them as well. So in any resus cases, similar to adults, usually we start with the general assessment and then A, B, C, D, E. So A is for airway, B is for breathing, C is for circulation, D is for disability, and then E is for the environment or exposure. If you're a medic, this would be like really simple to you, and if you're a medical student as well, you would know this. But in airway, we usually check if the child's airway is patent. If they're speaking, that's usually a good sign. If not, sometimes they might need interventions, and the anaesthetists are usually the ones who intubate them. And B is for breathing, so we check like the respiratory rate. We also quickly listen to the chest to see if there's any like silent chest, whether there's good air entry or any additional sounds, for example like wheeze or crepitations, which can occur in different scenarios. And then usually a whole lot of vital signs as well. And then C is circulation. So in terms of like vital signs, that would mean like the cap refill, the pulse, and the blood pressure as well. Usually at this point we also take a few type of blood samples. So this includes usually a blood culture to rule out any forms of infection. Usually we start antibiotics anyway, but we take a blood culture before starting antibiotics. And then the normal bloods like the full blood count, the CRP, which are inflammatory markers, the Usenis, LFTs. I just realized that there's actually a lot of medical abbreviations, but it stands for liver function test, urine electrolytes. It's called differently in the American system, but basically it's to check how all your organs and your systems work. And then for disability, we check their GCS score, and this is quite tricky in pediatrics because like GCS, or the Glasgow Coma Scale, looks at different things, right? So like your eye response, verbal response, and also like motor movements. But as you can imagine, if they're only so young, like in pediatric patients, some of them they can't even speak yet, so usually it's a little more difficult to assess. So we sometimes use the AVPU, which is the alert verbal pain and unresponsive score. And then for E, one very important thing is to look at is the temperature and the exposure to see if there's any rashes, because one sort of like a red flag would be like rashes that are non-lunging, which could signify very emergency or like very sinister conditions such as meningitis, which you need to pick up quickly and treat quickly because it can be quite fatal. And then after we've done like the primary assessment, which is the ABCDE, then we go through like a full detailed history if possible with the parents, or we look up the clinical letters just to get a bit more information about the child and treat them accordingly. So just in the middle of handover, we haven't even finished handover and there was a resource call put up. So everything's labelled here, so you can just look at it. Cannulation. So we've got the blue ones and the yellow ones. So the blue ones are a bit bigger for like older children, and then the yellow ones are smaller. And we also have neoform, which is like tiny baby ones, but they don't have here. It's on ward. So we've got, if we're taking blood cultures, then usually we need a blood needle as well. But if we're just doing normal bloods, then the blood bottles are here. And then we're not doing cannulation now, but if we are, then we've got some teddy bear stickers. So we have this thing in pediatrics called the vein finder. It's a device to see the veins superficially. It's quite helpful in pediatrics because usually in small children or like chunky babies, it's very difficult to see their veins, unlike adults. So let me just show you on my veins. It's quite easy. You can even see it without a vein finder, but you see if you shine the light, yeah, you can see like the darker areas, like that's the course of the vein. So then when you cannulate, you can follow that guidance. It's a lot easier than, oops. So I'm just prescribing some medication. Just put like the frequency and how long you want for. And then for pediatrics, there's actually order sets to help with the calculation. So if you just go to common, it's like Difflam spray, then you just look at the age and the weight. And then for, if it's outpatient, it will be prescription. You know what this reminds me of? You know the sound? We're going on a trip in our favorite rocket ship. Anyway, these are the ports. If we send bullets off, we put it here, close it, vision, put it in this thing, and when you close the door, it gets stuck up. Go straight to the lab. Pretty cool. The staff kitchen. Very nice. There's a microwave, and then these are like just snacks that parents can have. And then this is like a little quiet area where they can come in. Like books here. And then there's some information here, for example, on like safer sleep for like babies and premature babies, and like co-sleeping and all that, like, which is quite helpful, especially if they're like first-time parents. before we see newborns especially, it's very important to wash hands because their immune system is not that great yet, so they pick up infections really quickly. So I'm just going to briefly say like what kind of patients we see in PAU. It's actually a whole range, and because in pediatrics we see a wide age group, so they can be like newborns all the way up to 16 years old here. So different things that we see in PAU include babies, like newborn babies with jaundice usually, or sometimes even cow's milk protein allergy. And then in the older children, it varies like from system, so similarly to adults, like there are different things, but usually the conditions are quite different. So like for chest, it can be like if they have a background of cardiac issues, and then like for chest, common things, especially in the winter, include exacerbation of their asthma, viral-induced wheeze or bronchiolitis for small babies, which means their airways are inflamed and it's quite difficult for them to breathe, and sometimes we need to give them a bit of oxygen treatment or even support them with feeding, so we use NG tube, which goes into their nose and all the way into their stomach. And then for like abdomen or like tummy, sometimes we get patients with query appendicitis pain, so we would see them here in PAU first, and if we think that clinically and from their bloods like it is consistent with appendicitis, then we refer them to the surgeons who will review them and then bring them to theatre if needed. Neurological, there's quite a lot here actually. A whole different range from like cerebral palsy or just random different things like meningitis for infections, or even sometimes like metabolic conditions which manifest as like neurological conditions. And then we do see patients that come in for like falls if they fractured their hip or like their ankle, then usually the orthopedics team will see them as well. And then just common infections like ear, nose and throat, that's very common in pediatrics as well. Yeah, so usually they get triage and then they get weighed, and we usually see them, and then if they need admission, we send them to the ward. If not, then we give them some safety netting and then we discharge them home. So just finished the night shift. I'm back home now, and usually I eat a full meal if this is like night 1, 2 or 3, but then because this is the last night, I'm just having some breakfast. Got my protein cereal. It's called cereal. I like that. Anyway, it was a good night, and like it's actually a really good feeling like during the last night, finishing like all the shifts and just knowing that you're at the end of the stretch. Yes, sorry, my brain's not really working. Yeah, but overall I think the patients that we saw, there were quite a few like interesting, like stranger cases, but overall I think it was quite good. Like we had a really good team. The registrar was really nice, and I aspire to be like that one day, hopefully, like good clinically but also like in leadership skills and communication. It's really good, and nurses were amazing, HCAs as well. So overall it was just really good. Like I feel like when you're working in a good team, like it really makes a difference because there's like good vibes, you know, and even though it's like so busy and so hectic, it just, I don't know, it just feels nicer just working together. So I'm just gonna have my breakfast now and then try to take a short nap and then wake up and try to normalize my sleeping schedule again. That's the tricky part because I'm back on day shifts in 2 days from now, because in the UK there's this rule: after a stretch of night shifts you have to have a break for 46 hours, just for like safety and productivity and all that, mainly safety, patient safety. So I need to switch my circadian rhythm back. I'm not sure if this is controversial, but I actually quite enjoy night shifts, apart from the fact that your sleeping schedule gets a bit messed up, but I actually quite enjoy it because I think it's more clinical compared to day shifts. There's not a lot of, you know, like admin kind of tasks, because in the night shifts you're running on like a very minimal staff level, so you usually deal with a lot of the high acuity or like acute clinical cases. So I don't know, I find it more interesting and fulfilling. And also another thing I like about night shifts is that because you usually do a stretch at one time about 3 or 4 nights together, usually you get to know the patients like really well and the families, and it's just quite fulfilling to see like the outcomes. It's a bit more tangible and you can see like their improvement over time, and you get to know the families, and it's just really nice. Like you get to speak to them, you know, you're not as rushed as compared to the daytime because you just have a bit more time to sort of just talk to them, you know, get to know them as well. Anyway, hope you enjoyed this. I don't know how this will turn out actually. I think it's quite all over the place, but hopefully you've seen like something, and if you have any questions or anything you'd like to see further, just drop them down in the comments below. Take care, bye, see you in the next adventure.